Hello everyone, today we are going to discuss an array of mood disorders from unipolar to bipolar. So let's get started. What we want to do for today is look at the diagnostic criteria for mood disorders. So what we're going to look at are things such as major depressive disorder as well as the various bipolar disorders. We're also going to look at different statistics concerning the age, gender, and ethnic differences in the prevalence rates of mood disorders, because a lot of this is going to be due with shifting social norms, possibly systematic racism we can look at. They're not mentioned in our text. It doesn't go that in depth, but we can think about that a little further. Identifying common risk factors for mood disorders, that's important, as well as knowing effective treatments of mood disorders. We're going to talk about therapy later, but this is also looking at pharmacotherapy as well. So before we get started, if you or anyone you know is in need of help, possibly thoughts of suicide or self-harm, you can call the National Suicide Prevention Lifeline anytime, anywhere, even in complete anonymity. The number is here, 1-800-273-8255. I always like to put this number out there in case anyone is in need when we start, especially talking about depression, because it's something that affects a large percentage of people, especially in their mid-20s. So that's important that we talk about these things and kind of tear apart the stigma. And you can contact the BCC counselors. I forgot a C. They're heavily trained in these areas and other mental health areas, so if you are having troubles with anxiety, or maybe you don't have a major psychological disorder, maybe you just need help sorting through your thoughts, maybe you're overwhelmed with your schedule, they are a great resource for all of us here at BCCC, so I put the link for their numbers and emails right there. Now, when we talk about mood disorders, we're going to look at consistency and how these mood disorders affect people on a routine basis. So it affects their everyday functioning, it causes significant distress, and it's going to be a constellation of symptoms. So it's not one major symptom. We're looking at the different criteria put forth by the Diagnostic and Statistical Manual of Mental Disorders, or Psychological Disorders, excuse me. And so when we say constellation of symptoms, think like a constellation of stars, right? You have different stars that make up the whole image. Well, that's what we're looking at here in terms of mood disorders. Now, everyone gets in their certain moods. Maybe you found that you were just a little bit feeling depressed for a couple days. Maybe you ate too much or ate all your snacks in your house because you were feeling a little depressed for a couple days. That's going to be different than a mood disorder, and we're going to see just exactly how that is. So before you jump the gun and think that you have depression, maybe you can investigate the signs and symptoms a little further. Again, like I said in my anxiety post, it's easy to kind of have our confirmation biases come through when we talk about this material, because we can think, oh, I have this, oh, I have that. But we should really leave the diagnosis up to a professional. But if you do feel like some of this stuff matches you, use that information on the last slide to, talk to somebody. And so we're going to look at what a major depressive episode is, manic and hypomanic episodes, unipolar mood disorders, as well as bipolar mood disorders. So think of unipolar meaning one mood, whereas bipolar meaning two. So with major depressive episode, or MDE, this is going to be where we have all of these symptoms listed on the left, right? You don't have to have all of them to be diagnosed with a major depressive episode. You have to have 5 of them, 5 out of 9 at least, but you must have either 1 or 2 or a combination of these 2 for at least 2 weeks. And these symptoms are going to co-occur, and they are going to have significant distress and functioning and impact your functioning in your daily life. So feeling down is going to be a common trait of a major depressive episode, or depressed. Anhedonia. So this is just the loss of things you previously found interest in. So maybe you really like to play video games, and all of a sudden you're having, a bunch of other symptoms as well as not enjoying video games anymore. That could be a sign of a major depressive episode. And so we see there's a depressed mood, diminished interest or in pleasure in almost all activities, that's at anhedonia, significant weight loss or gain, or an increase in or decrease in appetite. Sometimes people emotionally eat or do not eat. Insomnia or hypersomnia, so the inability to sleep. Psychomotor agitation or retardation, so maybe you're psychomotor, so we're looking at different parts of our motor functioning and the brain and how that works. Fatigue or loss of energy, so feeling tired or lethargic, that's a huge symptom of a major depressive episode. Feeling worthless or excessive or inappropriate guilt, so this is part of the thought pattern that pervades depression and a major depressive episode. And we're going to talk about that global, internal, stable thought process in upcoming slides. Diminished ability to concentrate and recurring thoughts of death, suicidal ideation, or suicide attempt. I don't know why self-harm wasn't listed, but sometimes that can be, a sign or symptom. Remember, you don't have to have all of these, but just a majority to be diagnosed with a major depressive episode. So if you have a combination of these for at least 2 weeks, and it's causing significant distress or impairment in your daily functioning, such as you're not able to go to work because you're so tired, or you're not sleeping, or maybe you're losing interest in things, you just don't feel like leaving the house, and you're heavily depressed, and you feel worthless, like, your job would be better off without you. Those are an example of how someone would think with a major depressive episode. Now, a manic or hypomanic episode is going to be kind of like the opposite. It's going to be a distinct period of persistently euphoric, expansive, or irritable mood, and persistently goal-directed activity or energy. So mania, or that euphoric sense, is that really, really, really good feeling. Like you feel like you're on top of the world, and it's all great and rainbows and butterflies, right? Well, mania is going to be a more severe euphoria. It's going to be heavier than a hypomania. So hypomania, you're still going to have this euphoric feeling, but it's not going to be as grandiose as mania. So hypo, think under mania or something like that. That might help. But in order to be diagnosed with a manic or hypomanic episode, you need to have these symptoms for at least 1 week for mania and 4 days for hypomania. And so, with the DSM criteria, you need at least 3 of the symptoms on the left. So, inflated self-esteem or grandiosity. So this is the idea that, like, our self-esteem is how we feel about ourselves. So it's this inflated positive feelings. We kind of feel, if you are going through a manic episode, you feel kind of impervious to the world around you. You may feel that nothing can happen to you and you are on top of the world. So you have a reduced need for sleep, racing thoughts or flights of ideas, distractibility, increased talkativeness, and excessive involvement in risky behaviors, again, stemming from that idea that I can do anything. I'm going to use a personal example. I have an aunt who has bipolar depression. And what that involves with her manic episodes is that she feels impervious to danger. So she will start physical fights with people if she's in a manic episode. Now, that's not saying everyone would go through that, of course, but it's an example of this feeling of invulnerability, like just you can do anything. And that's kind of what happens. Sometimes these people in manic episodes will spend excessive amounts of money. That's another way that this kind of manifests itself in a behavior. Now, unipolar mood disorders are going to we think of polar ends like a magnet, right? We have, or like think of the North Pole and the South Pole, we think opposites. Well, unipolar is just going to be one end of the spectrum. So these mood disorders are going to focus on depression and having that lower mood state. Whereas bipolar mood disorders are going to switch between the depressive state and the mania states. So that's the main difference that we're looking at here. But with major depressive disorder, you have one or more major depressive episodes with no instances of mania or hypomania. Again, because you're staying on one end of the spectrum. And we looked at those symptoms previously of that major depressive disorder. So those symptoms are going to overlap. And what we're going to see is that if someone doesn't meet the exact criteria for major depressive disorder, because major depressive disorder is going to last for a certain span of time. I believe it's 6 months. I don't know if that has changed, and I don't want to lead you in the wrong direction. Well, it does not say in our text, and that's unfortunate. I'll find it for us so we can look it up. But for persistent depressive disorder, cannot be without symptoms for 2 months plus. So this is going to span 2 years. Okay, so you're like, well, how does someone experience major depressive symptoms for 2 years? That's a lot, right? Well, think of persistent depressive disorder as I don't want to say it's not as severe as major depressive disorder, but it's persistent in that it's duller. It doesn't have some of the more severe symptoms that we're looking at. So while it's longer in duration, the symptoms you'll see on the right they overlap with major depressive, but they're not like suicidal thoughts. So you have that poor appetite, insomnia, low energy, low self-esteem, poor concentration, feelings of hopelessness, and they will affect our daily tasks of living, for example. But they're not going to be, one of the major differentiations is that for persistent depressive disorder, it's going to be on an ongoing basis. So you cannot be without the symptoms for 2 months plus. So let's say someone's going through this for the 2-year requirement. I'm just going to say requirement. They can't have a 3-month gap somewhere where they don't have any of these symptoms or don't have the combination of symptoms, because that doesn't fit the DSM criteria. Now with bipolar mood disorders, we're going to look at 3 different types. So bipolar 1 disorder, bipolar 2 disorder, and cyclothymic disorder. So bipolar 1 disorder is just basically, this is what's known as manic depression formally, and you have a single manic episode where the depressive episode is not necessary. Whereas bipolar 2 disorder, you do have single or recurrent manic episodes and depressive episodes. Whereas cyclothymic disorder, think cycle. So there's numerous alternating periods of hypomania and depression. So you're flipping back and forth through those different cycles. So you're going to experience symptoms half the time with no more than 2 months of symptom free. So make sure you read this part in your text to be able to differentiate between the 3. Mostly, I would say as you progress through the numbers, they kind of build in their switching. And so the reason I put this light switch here, switching between the polar ends, for example. The reason I put the light switch here is that some people use bipolar in common lexicon to mean someone flips back and forth immediately. Well, that is not the case with bipolar mood disorder. These episodes are going to last, like we saw, a hypomanic episode is 4 days. A manic episode is a week. It's going to be a longer duration of time. Someone's not going to flip in 2 hours between the different polar ends. So just kind of make sure you can differentiate that and know that, try to strip away that quote-unquote common knowledge that's been ingrained in our brains. Now with depressive disorders, we're going to look at the statistics of depressive disorders compared to bipolar disorders and who they affect and what are risk factors. Now for depressive disorder, depression is unfortunately very common among people in the United States. And it's unfortunate because it sucks to have to live with these kind of things if I'm going to be blunt about it, but also there's a stigma still attached to it. So what we're trying to do by educating ourselves is peeling away that stigma so we can talk about these different things, right? Because typically what we're going to find is that 16.6% of the population has been diagnosed with major depressive disorder. That is a large percentage. And the average onset is going to be in the mid-20s, and we find that this age for diagnosis is decreasing. Now, it could be, oh, things are changing, there's a lot more pressure on younger people. We can kind of hypothesize why these things are happening. But I also want to put it out there that because stigma is changing surrounding depression, they're also more likely to go to therapy to get help. Whereas, people of our grandparents' generation, for example, it was very stigmatized. You didn't talk about it. A lot of times people engaged in substance use and abuse, such as alcoholism, to kind of deal with their depression, rather than trying to see a therapist because that was something quote unquote crazy people did. So it could be that we are stripping the stigma away, and so more people are seeking help, and that's why we're having higher numbers. So I just want to put that thought out there. Typically what we find is that recovery typically begins within 3 months. Unfortunately, depressive disorders can be cyclical. Sometimes people have to continue going to therapy to work through their issues, and we're going to talk about the different therapeutic techniques. But it's also co-occurring with anxiety disorders. 59% of people diagnosed with major depressive disorder also have an anxiety disorder. So it kind of shows like how our mental health can affect multiple facets. And so one thing, you guys can read through the statistics, but one thing that's interesting is that European Americans are more likely than African and Hispanic Americans to be diagnosed with depressive disorders, but Native Americans are more often diagnosed and deal with depression at higher levels than European Americans, African Americans, and Hispanic Americans. But there are some health disparities in these certain groups that we won't have time to talk about in this video that may affect, there are cultural things that affect if someone can seek help, because in some cultures it's still not acceptable to talk about your mental health issues, or it's frowned upon, or someone's seen as crazy, right? There's all these labels. That's why I try to strip that stigma. And there are genetic factors that could be at play with depressive disorders. We found in twin studies, monozygotic twin studies, they share the same DNA, that there is a lot of overlap in depressive symptoms. There are environmental effects, but the main thing I wanted to stress was stressful life events can often, I talked about the diathesis stress model, how events can kind of trigger certain psychological disorders, right? So if someone has a significant relationship loss, like a divorce or a loss of income, like losing a job, these very stressful life events can act as a trigger for major depression. And sometimes early adversities such as child abuse, neglect, things of those nature can affect someone and how they function with depressive disorders. And most importantly, the attributional cells. So how do they think about the world? If they think of things in a very internal, global, unstable way, that says that they blame things on themselves. They think it's like a very generalized phenomenon, and it will always be this way. So it's kind of like, well, I did this way because I suck. I'm always going to suck, and that's just who I am. So it's very internal, stable, global, stable. It kind of catastrophizes things. Maybe taking a small thing like failing an exam and attributing it to being a complete loser. That's the kind of thought process we're seeing there. Now with bipolar disorder, often African Americans tend to be underdiagnosed, whereas Hispanic Americans are offered less medication, or not offered, I should say, but we've noticed less medications and interventions and specialty treatment visits. So this could be due to accessibility to healthcare or sometimes implicit biases in healthcare. And this is often bipolar disorders and depressive disorders are linked with substance use disorders, and this involves people self-medicating. But for the purpose of our course, I'm going to limit that because you can learn more about it in abnormal psychology. And I'm running out of time. So, risk factors for bipolar disorder. You're going to look at heritability again. The triggers aren't yet understood, but it's believed that sometimes severe stressors, as well as disruptions in someone's routine, such as their sleep routine or their daily lives, something with their circadian rhythm, if that gets disrupted, it's more likely to trigger a bipolar episode. Treatments and conclusion. So a lot of times we're going to talk about therapies later in one of the upcoming units in this section. Antidepressants are common for depressive disorders, MAOIs, SSRIs, and tricyclics. We've often moved to SSRIs now because there's less detrimental effects. Sometimes we have gastrointestinal side effects, the inability or delay in producing orgasm. The effects aren't as severe as they were with MAOI. I'm going to edit that part out. But they can also cause severe facial deformities where people kind of look like they have had a droopy face where they can't express their emotions anymore. Electroconvulsive therapy is also a great treatment if someone hasn't responded to drugs. This is electroconvulsive therapy where they use electrical impulses to stimulate certain parts of the brain. It has been shown to have great evidentiary support for success, but again, this is only if someone doesn't respond to the drugs. And psychosocial treatments, as always, these are going to be your therapies, your behavior therapies, so looking at changing actions that contribute to depression. Cognitive therapy, changing those internal stable global patterns of thought, and interpersonal therapy, addressing how they would deal with others and how they can create more pleasant interactions. For bipolar disorders, it's common to use pharmacotherapy, so looking at lithium. Now, a lot of times there's not good medication compliance with people with bipolar disorder because lithium decreases their manic episodes, and sometimes people with bipolar disorders who experienced manic episodes, they miss that feeling of grandiosity, right? So they stop taking the medicines because even though they get the lows, so to speak, they really want to get those highs back of the manic episodes. And also looking at interpersonal and social rhythm therapy, so establishing those routines for those people so that those stressors and circadian rhythm disruptors, we can kind of eliminate those so that we can minimize any of those scheduled stressors. I hope I covered that sufficiently in 23 minutes. If you have any questions, please let me know.